you do. So we, as I said, we are starting afresh on the acute inflammation. Okay, so we said that inflammation, according to what you've learned from your medical terminology with T.A. Hackman, when you hear any medical term that ends with itis, I-T, hey, what? Time. Let me write it well. That ends with I-T-I-S. Like as we say in carditis. My final year research, my project, I did it on acute myocarditis, which is inflammation of what the heart. So myocarditis and inflammation of the heart, and endocarditis is inflammation of what? The internal heart. We also have pancreatitis, acute pancreatitis. Okay, we have pleuritis, we have a whole lot of the gastroenteritis, which is signaling or which is telling you that there is inflammation in the organ of interest. Okay, we have osteitis, which is inflammation of bones, spondylitis, inflammation of what? The vertebral bones and all that. So one thing about inflammation is that it is non-specific. Okay, inflammation is non-specific. It doesn't matter the cause of the injury or the cause of the insult. The inflammation is the same. So it doesn't matter if the inflammation is due to some bad sepsis, some bad infection. The inflammatory response is the same. It doesn't matter whether it is due to a cut, it's the same. It doesn't matter whether it's due to radiation, the radiation injury, it is the same. It doesn't matter whether it is an ant bite, the inflammation is always the same. So it is a non-specific natural reaction to what? To injury and to insult to tissues. It doesn't matter whether the inflammation is as a result of tissue necrosis. It is always non-specific. It means that it is the same response to different causes of what? The injury or the insult. All right. Another thing that you should know is that there are 4 cardinal signs of inflammation that we look at. We have pain, redness, edema, what again? Heat, loss of function, and then there's loss of function. And as we look at the sequence of events that occurs during inflammation, we will be able to know why we have all these things. We have all these events, and we will also be able to know the chemical mediators that cause these actions to take place. Inflammation, the actors of inflammation are things that are triggered. It means that even though they will be in the blood, in the human body system, they will not be active. They will only be active if and when the cause, the triggering factors are activated, and then the triggering factors will cause the activation of these inflammatory actors before you have the response. Otherwise, the body would have been in a constant state of what? Inflammation, which is not good, which is not good for the body. Okay. Now let's look at the sequences of events, the sequence of events that take place in inflammation. All right. So the body will be in its normal state. the tissue will be in its normal state, the organs will be in their normal state, they will be in their homeostasis. That is where we start. We start at the place where organs, tissues, the body system, the organism is in its normal state. And then some insult will happen, some injury will happen, such as physical injuries, chemical injuries. The injuries can be biological, whereby we have some pathogens, bacteria, fungi, or protozoa invading some organ or some tissue and causing an injury. The injury can be as a result of autoimmune reaction. That will disrupt the body's normal homeostatic balance. When that happens, the next thing that we experience is vasodilation. First, there is a sharp, very short vasoconstriction. But what is more notable is the vasodilation, whereby the diameter of the blood vessels, in this case, the most important blood vessels that is affected or that undergo, or the blood vessel type that is important for inflammation is what we call the capillaries. 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 And sometimes in some special occasions we involve the arterioles and the venules, but the primitive blood vessel that is affected or that undergoes or actively participates in the inflammation is the capillary. So the insult will happen to the normal tissue. Then you have vasodilation. Vasodilation will cause what? The diameter of the capillaries to increase. And in that sense, there is going to be what? An increase in blood circulation. The amount of blood that occupies that particular portion of the capillaries will increase because there is more space at that place. That means that there is going to be more plasma at that area. And because the cells, the endothelium of the blood vessel, the capillaries, has stretched and dilated, there are now holes. There are now what? Holes between the individual endothelial cells. And if there are holes, that means that the water component of blood will now exudate, will now transudate, will now exudate and leave what? The vascular environment into the extracellular environment. So there will be vasodilation. There will be vasodilation. That vasodilation will cause us to have holes within the endothelia, increasing the vascular permeability. Now, when there is vascular permeability, the fluid component of plasma or the fluid component or plasma of the blood will now have the chance to what? To exudate, to leak from within the blood vessels into the extracellular space. Are you following? We only have 33 people here. 36. Okay, please call your friends. 38. We are increasing. Nice. The fluid component will exudate. So that is this portion is what we call, they all fall under what we call the vascular event. Vascular event. Sorry, Forgive my right, I'm writing with the mouse. Vascular event. Vascular event. Then the vascular event will end. Then we will go to the cellular event, which is classically from all these places up to this place, which is called the cellular event. So those are the two main events, the two main classes of events that happen sequentially during inflammation. The vascular event, where we have the vasodilation, increased permeability, then leakage of exudate. Then we have the cellular event. Under cellular event, we have margination. What is margination? We learned the last time that as blood circulates in the blood vessels, the red blood cell component of the blood flows in the middle. Okay, the red blood cell component of the blood flows within the middle, in the mid portion of the lumen of the blood vessels. Then we have the white blood cells loving to be at the peripheries. Okay, so we have blood vessel wall here. Then you see that naturally, homeostatically, you see the red blood cells. You see the red blood cells will be in the mid portions of what the lumen. Red blood cell, red blood cell, red blood cell. They will be in the mid portions of the lumen. Then the white blood cells are more like they have more affinity to what? To the peripheries of what? The lumen of the capillaries or all blood vessels. Now, what you should also know is that once there is vasodilation, there is going to be what? A proliferation of what? White blood cells and red blood cells in the lumen of the capillaries. So the number of white blood cells will increase at that particular area where there is that inflammatory response. If the number of white blood cells increases, the blood is going to slow down. The blood is going to slow down. The diameter has increased. The hydrostatic pressure is going to drop. The number of white blood cells is going to also increase. So there is now going to be a high likelihood that the white blood cells are going to be touching. They are going to make contact with the endothelia or the walls of the lumen of the blood cells. Now, as they make contact, these endothelia and other plasma proteins are going to cause some sort of adhesion, some sort of stickiness, some sort of attachment between the white blood cells and the lumen and the endothelia. So initially, these chemical mediators, they are called selectins. They are not very strong. So when the white blood cells bind themselves to the endothelia through these selectins, because there is water moving around the area, pushing the white blood cells to and fro, and the selectins are not that strong to hold the white blood cells onto the endothelia, they tend to attach and detach, which is called rolling. So we have margination, and this margination is bringing the white blood cells into contact with the endothelia. Now, as they come into contact with the endothelia, we have chemical mediators called selectins. They are adhesive molecules. Adhesive means that they cause the white blood cells to stick to the endothelia, but they are not very strong adhesive molecules. So the movement of the water, the movement of the blood is able to detach the white blood cells from the endothelia. So they detach and attach, until the time where some other chemical mediators called integrins, we will look at them into details, but I want us to have a very nice introduction so that when we kickstart, so these integrins are also adhesive molecules, but they are stronger adhesive molecules, right? Let me clean this. They are stronger adhesive molecules. So their strength makes them resistible to the the blood plasma's current, and is not able to what? Remove them from their contact with the endothelia. So now we have what we call adhesion. Are you following? Let me see if you are following. Show me some emojis, some claps, some smiles, and all that. Hello? Okay. Franco. Visa come again. All right. Let us continue. So now we are at adhesion. And I said that the molecules that mediate in adhesion, they are called integrins. So adhesion, we have integrins, integrins, and the ruling we have selectins. Hey, that's some more. Selectins. Hey. All right. So now the cells, the white blood cells, the white blood cells. And here, by white blood cells, I mean the neutrophils. The neutrophils. They are the most important. Good morning. They are the most important white blood cells in acute inflammation. The neutrophils. They are the first white blood cells to be called to a site of inflammation. So take note. Now we have our white blood cells adhered to the endothelium. Now what? The white blood cells, the neutrophils, are now supposed to transmigrate. They have to be able to cross the walls of the blood vessels, lumen. They have to cross the walls of the blood vessel and now enter into the tissue area where we have the inflammation, where we have the insult, where we have the bacteria, where we have the cut, where we have the tissue necrosis, where we have the radiation injury, where we have the free radical injury, where we have the autoimmune injury. So what happens is that these cells, these white blood cells, the neutrophils, they will squeeze themselves through the same holes that the plasma, the water, exudated from the lumen of the blood vessel into the tissue. They will also use that same place. Now, when they squeeze themselves, they will first pass through two barriers. The first barrier is the endothelia. So let's say these are the cells that make the walls of the blood vessel. Okay, the walls of the capillary, the endothelia. So these white blood cells, let's say these are white blood cells, they will then squeeze themselves. They will squeeze themselves through these holes, trying to escape. But that is not the only barrier they interact with. We have what we call the basement membrane, on which the endothelia are lying. Okay, it is called basement membrane, and every tissue is arranged on a basement membrane. This basement membrane is made up of a protein called collagen. The last time I told you about collagen. So we have collagen. And for the collagen, you cannot squeeze yourself through it. You cannot squeeze yourself through the collagen. So what the neutrophils do is that they secrete some enzymes called collagenases. Collagen, you spell collagen, and then you add ACE. In the exams or quiz, you have to know the name. Collagenases that will digest this collagen. They will secrete it, so the collagen will be digested. Okay, so now this portion of the collagen will be digested so that the white blood cells, can now pass through these holes and then come into the tissue where there is an injury. Okay, so that is what we call the transmigration or the diapedesis. Now, there has been transmigration. The white blood cell, the neutrophil, has been able to penetrate the cell lumen into the tissue spaces. So now what? You have come to the tissue space. So what? Like what about then? How about tissue space in then? So now the white blood cell has to be able to go to where the injury is, because the body and its tissues are plenty. Like, it's a large place. So you need to go to the specific place where there is the injury. So whenever there is an injury in the tissues, there is an injury in the tissues, the injured cells, the dead cells, and other cells in that vicinity where there is the injury, where there is that necrosis, they will release chemokines. Okay, they release some chemical mediators that we call chemokines. We have interleukins. We look at them. Interleukins, tumor necrosis factor, and all that. They are collectively called chemokines. Chemokines. Chemo what? Kines. And these chemokines, when they are released into the tissue spaces, they are the chemicals that will what? Guide the white blood cells to know that, okay, the inflammation is happening at this place. So come. So the neutrophils will follow these chemokines. The neutrophils will follow the chemokines. Let's say these dots I'm creating, they are the chemokines. So it will follow the chemokines up to the place where there is what? The inflammation. There is the injury. So it will not go to this direction where there is no chemokine. It will not come to this direction where there is no chemokine. It will not come to this direction where there is no chemokine. But it will follow these chemokines into the place where there is what? There is that inflammation, there is that insult, there is that injury, there is that bacterial infestation. So the process by which the neutrophils or white blood cells follow to be able to follow the process by which neutrophils, white blood cells, follow these chemokines to be able to locate the place, the site of injury is what we call what? Say it, chemotaxis. Are you following? That is what we call what? Chemotaxis. Everybody type chemotaxis, medianic chemotaxis. Type chemotaxis into the chat. Chemotaxis. I will ask you to explain it in the exam. So make sure you know how to spell it. So spell it into the what is saying. That thing. Chemotaxis. Yes, let's go. Okay. So that is chemotaxis for you. Now, white blood cell, you have chemotaxis into the site where there is the injury. You have chemotaxis. So what? What chemotaxis abanti anyway? What happens? You have chemotaxis. So like for what? What are you coming to do? Remember that I said that in the beginning of the class. I said that the actors of inflammation, they are there, they are in the blood vessels, they are in the system, they are in the body, they are in the tissues, but they are in their latency. They need activation before they can act. Otherwise, they would have thrown the body into chaos. There would have been chronic inflammation every day, and you see everybody feeling hot, looking pale, looking red, looking hot, looking big, right? So the white blood cells, after they've gone to the site of injury through chemotaxis, they have to be activated. They have to be activated. And this activation has their own chemical mediators, which we will talk about very soon, so that they will know that, oh, okay, we are at the site of injury. And this particular structure, this particular body, this particular organism I'm seeing here is a foreign organism. So we have receptors on the surfaces of the neutrophils and other white blood cells that when they bind to other chemicals within the injured tissue, when they bind to some portions of bacteria and other foreign bodies, when they bind to some substances that are released by these foreign organisms, they get to know that this person is here. There is a foreign body here. There is a foreign body here. Now let me go and deal with it. Deal with it, pa. Then there are other things that will cause degranulation of these lysosomes so that they become ready to attack whatever it is there. Now, after we have had the activation of our neutrophils, the neutrophils, they kill primarily by what we call phagocytosis. So there is a recognition of the foreign body or the dead cell through receptors that bind to them, receptors that bind to the foreign body or the injured tissue or whatever is there, receptors. Now, after recognizing them through receptors, there is going to be what we call attachment. The white blood cell, the neutrophil primarily, is now going to attach itself to whatever foreign body, foreign substance, or invader or dead tissue is there. From there, it's going to what? Engulf. And we learned the last time that there are some fibrins, some biomolecules that form the cytoskeleton of the cell membranes and enable them to undergo this engulfment. Now, after the tissue or whatever substance has been engulfed, we create what? A phagosome, a vacuole, a dedicated vacuole for it. So the bacteria doesn't mix with the cytoplasm of the neutrophil, otherwise it will die. So it has to create a dedicated, so we have, I'm coming, let me show something graphic. We have our neutrophil here, our neutrophil is here. Then with receptors, it will detect that we have a bacteria here, very bad bacteria, causing problem. Now, after it has detected, now it is going to undergo attachment. So attachment, it is going to give some nets to attach itself to this bacteria. After attachment, then we have our bacteria here are going to undergo engulfment. Okay, I'm going to have our engulfment here, and eventually this bacteria or whatever injurious substance is going to be fully enclosed by the cell, the white blood cell, and then it will have its own dedicated what? Vacuole called phagosome, right? And then from there we are going to killing, whereby the lysosomes of the white blood cell will bind to the phagosome and then release its enzymes, lysozymes, or free radicals like hydrogen peroxide, superoxide, hydroxyl, whatever, onto the bacteria and then kill it through the degradation with the free radicals, nitric oxide, whatever, or digestion by what? Lysozymes. Now, after everything has happened, after all the injurious substances or dead cells have been removed, then we will go towards termination of the whole inflammatory process. Then, after termination, we go to resolution. Then we go to tissue repair, where we have scarring. In instances whereby the injurious substance is persistent, we will graduate into what? Chronic inflammation, which involves more potent and more long-lasting white blood cells. Talk about mast cells, talk about macrophages, and so on and so forth. So these are the three possible outcomes of inflammation. At first, we have an acute inflammation. At the end of the acute inflammation, we can go into resolution, whereby the inflammation stops, or there will be tissue repair anyway afterwards, but the tissue repair wouldn't send the tissue into its normal state as before. So the normal tissues will be replaced with what? Scar tissues. That is why a lot of people have scar tissues, or the inflammation will continue for a long perpetuated time, called the chronic inflammation. All right. So this is the sequences of events that we are going to look at. Yeah, just getting started, but I think with this introduction, we are going to have a very good time, entertaining time from now to the end of the class. So let me see your reaction. Are you impressed? Are you impressed? Show me some claps. Yeah, I love you too. I love you too. Please, do you have any question? If you have any question, do type it into the chat box. Let's look at it. Michael Sadi. Hey, every day you are crying. Hey, come see me. Come see me. Okay, upon Emmanuel is asking me the difference between myositis, ossification, and scar. So these two are so different things, like distinct things. In myositis ossificans, I think there is there is an injury, there is a chronic injury to the muscles, and the muscle tissues are trying their best to be able to withstand this injury, but they are not able to do that. So they will undergo what we learned, that metaplasia. So myositis ossificans is a metaplasia reaction. Metaplasia. The injury is persistent, and it is not something that the muscles are able to withstand. So the muscle tissue is replaced. They undergo metaplasia into what? Bone, calcified bone tissue, so that bone tissue will better be able to withstand uh, whatever cause of injury there is. But for scar, it is after an inflammation, the tissue is damaged, and the tissue is not able to repair to its full state. So the component of the tissue is now replaced with a protein called collagen. That's what gives us the scar. So if the scar is on the skin, the epithelial tissues are not able to regenerate. So the body, in its attempt to heal itself, will now replace the epithelial tissues that are failing to regenerate with what? Scar tissue. The scar is a protein. Okay. So that is metaplasia, the myositis ossificans. Okay. Let's move. So, as we said earlier, acute inflammation is a protective response. Okay, it is not a bad thing. Inflammation, in and of itself, it's not a bad thing. It's the body's what? Mechanism to protect itself against any insult or any injury. And as I mentioned, it is not specific. It doesn't matter what the injury is, it is the same response that is coming. The body will give the same response. There is going to be vasoconstriction, sharp, then vasodilation, then all those events will progress as they do under normal circumstances. So it is not specific. Now, we have two main events that happen when we have acute inflammation, the vascular event and the cellular event. The vascular event includes that sharp vasoconstriction followed by a long vasodilation and then vascular permeability, vascular leakages, and what have you. Then the cellular events include when we have the polymononuclear neutrophils or other leukocytes marginating and now rolling and now getting adhering to the endothelia and now undergoing the diapedesis or transmigration or diapedesis, then followed by the chemotaxis, then activation, then phagocytosis, killing and degradation. So that is the portion that the cellular events have to do. And we said that inflammation is not something that is perpetually ongoing. The actors and the factors of inflammation need to be activated before they can act. And these what causes them to be activated and to act is what we call the chemical mediators. Chemical mediators, which we will look at. After the class, I will show you a link to get the source of this slide, okay? So don't worry. Now, acute inflammation. And we said that the main white blood cell, the main type of white blood cell that takes on the acute inflammation is a neutrophil. And morphologically or at the histological level, you see this is the neutrophil. This is the neutrophil. It has multiple nuclei or nucleuses. I don't want to confuse you. The nucleus of the neutrophil is more than one. Every neutrophil has more than one nucleus. Then we have these dots inside of it, which are granules. These granules contain a lot of lysozymes and other killing substances like the nitric oxides and what have you. So when it is ready to devour whatever it has phagocytosed, then these things are degranulated, meaning they are released to be able to attack whatever chemical or whatever is there. Let's continue. Now, the main features of inflammation is rubor, calor, tumor, dolor. So we have redness, we have pain, we have swelling, we have heat. Then the fifth one is a functional laser, what we term as a loss of function. Probably because of the pain and the swelling, the particular organ, the particular tissue which is under attack, which is undergoing the inflammation, will not be able to perform its function as it used to under homeostatic conditions. So the stimulus for the acute inflammation can be any stimulus. As we said, inflammation is non-specific. It's a non-specific response. So whether the injury is infectious or physical injury like a bruising or a scratch or a bite, or chemical injury like whether it is poisoning, whether it is acid something, or whether it is tissue necrosis, it doesn't matter what type of necrosis it is, whether it is liquefactive, gangrenous, caseous, whatever, whether it is foreign bodies like bacteria, protozoa, fungi, mosquitoes, whatever, whether it's the immune response, everything, the same response, acute inflammation. Now let's talk about the vascular changes. The vascular changes, we have two main vascular changes. The first is what changes changes in the vascular flow and caliber, change in hydrostatic pressure, change in the thickness of the blood vessel, change in the lumen size of the blood vessel. Okay, so change in vascular flow. When there is vasodilation, there is now more space within the lumen. So the speed, the hydrostatic pressure with which blood is moving through these blood vessels decreases, it slows down. There is a change in the caliber. Now the blood vessel becomes more turgid because there is a high quantity of blood lodged in there, in that particular segment where we have that inflammation. Then we also have the increased vascular permeability with the vasoconstriction, vasodilation. We have the endothelia contracting, and with the contraction, the tight junctions, the junctions between the various cells that make the lumen wall of the blood vessel, there are now more holes within them. There can also be an instance whereby there is an injury like a prick, a pierce, that is directly injuring the blood vessels. And when the blood vessel itself is injured, now there is even going to be more vascular flow. Things can even flow freely through the blood vessel wall into the tissue spaces. Do you understand? So we have increased permeability in such instances. Now let's look at the increased permeability shortly. So the dilatation, the endothelial gaps, direct injury to the blood vessel wall, leukocyte injury. What is leukocyte injury? I mentioned that sometimes when these leukocytes bind to the endothelia and they're able to penetrate it, they secrete collagenases, and these collagenases digest the collagen of the basement membrane of the cells, and they're able to pass through it. The transcytosis is where we have this diapedesis, whereby the neutrophils are able to pass through the blood vessel walls. And during inflammation too, we have angiogenesis. Okay, angiogenesis, whereby the body with its own mechanism causes the creation of different routes for blood circulation. And all these things constitute with an increasing permeability. Do you understand? Okay, we will talk about the opsonization. All right, we will talk about it. Some of you are leaving. You guys tell them to come back. Let's continue. So, when there is vascular permeability, of course, there is going to be leakage of the proteinaceous fluid, the plasma component. And that leakage is an exudate, not a transudate. The last time we looked at the difference between exudate and transudate, we said that exudate contains what? A lot of proteinaceous substances. So plasma proteins mixed with water and some cells constitute the exudate. And the transudate is only about clear fluid. So the difference between exudate and transudate is classically about what? The protein component of the liquid. So you have extravasation of what? The neutrophils. The extravasation is about the neutrophils moving from within the lumen of the blood vessels into the tissue spaces. And for the radiographers, extravasation injury is something that you look at. I think when you are treating CT and MRI, the contrast agents, when you give the person the IV line and you don't put the line into the lumen of the blood vessel very well and you give the contrast, you see that the contrast will now move from the blood circulation and then they will be in the tissue spaces called extravasation. Okay, so there is margination. The neutrophils will move towards the peripheries of the blood vessel wall. From there, we will have our rolling. They attach and detach, attach and detach, attach and detach. And with that ongoing, we will have a lot of what? Leukocytes in the blood lumen. Eventually, there is adhesion. They are going to now stick tightly to the endothelia. Then there is transmigration, diapedesis, whereby they now move intentionally under the neutrophil's own processes into the tissue spaces from within what? The lumen of the blood vessel. Now, we have adhesion molecules or glycoproteins that affect adhesion and transmigration. We have secretins, or selectins. I think you find out, go and find out two of them, which of them is the correct, or which of them is more accurate, or which of them is more active. We have the secretins from the endothelial cells. Then we have the integrins from many cells. Many cells produce the integrins. We have some that are produced by the neutrophils themselves, some produced by the endothelia, some produced by even platelets and other cells that circulate in the blood. We also have the secretins. The secretins or the selectins, those ones are produced by the endothelial cells of the blood vessel themselves. So we have chemotaxis, whereby the white blood cells follow some chemical mediators to enter the site of injury or insult after transmigration. Then when the leukocytes get to the site of injury, they have to be activated. They have to be triggered. And this activation or triggering is as a result of the leukocytes binding themselves or coming into contact with the offending stimulus, whether some chemicals produced by these bacteria or whatever, or the dead cells. When there is necrosis, we learned that the organelles, intracellular organelles, are burst into the extracellular spaces. So these neutrophils are eventually going to come into contact with some of these organelles, and it's going to activate them to know that, okay, this is the place, and let's start working. So when they are activated, we have production of eicosanoids or arachidonic acid derivatives, prostaglandins, leukotrienes, lipoxanes, and all that in response to the activation. And you see, these prostaglandins and arachidonic acid, leukotrienes, cool. They are chemicals which cause you to feel pain. And when they are released into the systemic circulation, they have an effect on the temperature centers of the brainstem, and then they will make the person feel hot. So that is why we have pain in inflammation, and then heat in inflammation. And the arachidonic acid pathway is what generates these prostaglandins, leukotrienes, lipoxanes, and what have you. So we have these non-steroidal anti-inflammatory drugs. A classical example is the ibuprofen, which comes and then messes up with the arachidonic acid cycle pathway so that it doesn't go into completion, and then it stops the inflammation. Okay. After the production of the eicosanols, as I mentioned, the leukocytes are going to undergo the degranulation. This one, the lab people will know that the leukocytes, especially the neutrophils, they are granular. If you stain them, they are granular. And that granules is together with other things, the lysosomes and the lysozymes that they contain. They also secrete cytokines to enable them to kill off these foreign bodies. The next thing we have is phagocytosis. And yeah, we have recognition, engulfment, killing, and degradation, as we spoke about later on, earlier on. Now, let's look at some of these chemical mediators. These chemical mediators, as I said, they are the substances or the biomolecules that activate the inflammatory actors. They are either produced or found in the plasma, already there in the plasma, or they are produced by these cells. If they are in the plasma, it means that they are produced by the liver, classically. When they are in the cells, maybe the endothelia and then the neutrophils and other things, means that they are produced within these cells, and when the trigger that causes their release is present, then they will be released. And they have specific targets. They have specific cells that they communicate with. And then the release of a little bit of these chemical mediators will cause other cells, similar cells within that vicinity, to also release their own. So you see that within a very short time, we have a lot of such chemical mediators produced. That is the meaning of this cascade event. Okay, the cascade. And they don't stay in the system for long. They are quickly degraded, meaning right after the inflammatory response has ended, you see that they also be degraded and they will also leave the circulation. So classic mediators, we have histamine, which is a very strong vasodilator. We also mentioned that the histamine is produced by the mast cells. It's also what do we call it? Histamine. This process, this condition whereby the body reacts to normal substances as if they are some injurious foreign body. The friend is allergic reaction. We also have serotonin, complement, kinase. We have clotting factors, eicosanoids, nitric oxide, platelet activation factors, and what have you, free radicals, neuropeptides. We will look at them one by one very sharply. We will end the class soon. So histamine, produced by the mast cells or basophils, they are vasodilators. They are vasoactive. Okay, so they are able to cause the blood vessels to dilate when they come into contact with them. We have serotonin, produced by the platelets and enterochromaffin cells. They are also vasodilators, but not as direct as the histamine. We also have the kinase system, the chemokines. You have the bradykinin, which is a key component. Bradykinin causes pain. It also increases cellular permeability, muscle contraction, and then cause pain as well. Non-vascular. I don't know what they mean by non-vascular. I'm going to find out. Okay, so let's end the class here. Let's end the class here, and sometime later, maybe on Sunday, we will continue, and then we will finish up with everything. The chronic inflammation is very short, so we will continue with the acute inflammation and go. But now, let me chip in this thing. The last time I was teaching something and you guys were not getting it. And the way everybody's face had become monzon and angry, I was like, what is going on? What I was trying to explain was that we've learned that these are these steps are the cellular events that occur during these are the cellular events that occur during inflammation. Okay, so we have adhesion, rolling, margination, adhesion, chemotaxis, diapedesis, activation, phagocytosis, and co and co and co and what have you. Now, all of these steps, if you remove even one of them, it is a sequence. So if you remove, if something happens and even one of them doesn't occur, it means that the inflammation is not going to occur. It is not going to go to completion. So we will not have a complete inflammatory reaction. We will not have killed the bacteria or cleaned the necrotic tissues or do whatever we wanted to do. So for inflammation to go not into completion or to go wrong, it is either there is some genetic issues that is messing up with the body's ability to undergo white blood cells from being able to undergo either margination or the adhesion is not taking place. Adhesion is not taking place, or something that is causing us to not have the transmigration or the chemotaxis, whether it is the chemical mediators that are not being produced or the collagenase that is used to digest the collagen of the basement membrane that is not produced, or something is affecting the chemotaxis, whether it is the white blood cells that are not being sensitive to the chemical mediators that act in chemotaxis, the tumor necrotin factor, the interleukin 1 or 2 or whatever. Or those chemical mediators are not being produced at all, or the the white blood cells are not being able to be activated, whether there is something wrong with the receptors that are able to recognize bacteria and other bad molecules or external molecules, or whether there is something messing up with the body's ability, with the white blood cells' ability to undergo the phagocytosis, or there is something happening so that the white blood cells are not able to release their lysozymes, or the lysozymes are not produced at all. So you see that all these are important events that need to happen before we can have a complete inflammation, before we can have a complete resolution, before we can have a complete cleanup of whatever the inflammatory factor is. So if any of these is now unable to be produced or responded to, then there is a problem with the inflammatory process. All right, let's pause here. I've had a very nice time with you guys. Show me some emojis that you really enjoyed the class. Let me put the link here. I'm coming. I sent this to you a long time ago. It is part of the links I sent to your platform some time ago. So I'm putting it into the chat box right now. Copy it, click on it, and then view it. Watch them. All right. Enjoy your day. See you on Sunday. See you around. If there is anything, you can come to the office. We'll talk about it. Please write your questions and then we will look at it. So inflammation is not pathologic. It's not pathologic. It is some pathological event that will cause it, but it's the body's means of defending itself against that pathology. So of course it is pathologic, but it is not. It is the body's response to pathologic event. Okay, I don't know how best to understand that. All right, bye bye everybody. Have a nice time. Those of you who have questions, we'll talk about them later on.